Good morning, good midday, good afternoon, wherever we're reaching you on Let's Talk SADS Live Canada. I'm your host, Dr. Shubayan Sanatani, and I'm coming to you from Vancouver on this June 20th. Great to be back in the SADS studio and really excited about today's show. New frontiers in patient-centered HCM care, and we're going to dive into that very shortly. I've been traveling since we last spoke, and enjoying some of the spring. We have a lot of wildfires here, so that's not good. Let me find a couple of slides that I want to share with you, and here we go. All right, so hopefully you're seeing something that is the title and reminds us this is a place where we're all just here to learn from each other. And I look forward to our guest and your questions. And thanks to our executive director, Pam Husband, who came up with the idea for us to reach out to our public a little bit. And we've been doing this now for about 6 months, and so far I think it's been going okay. But I'm the last person to know. Couple of important things to mention today. So we're in the relatively early stages of planning some fundraising, and you hear me talking about fundraising not infrequently. And people should probably say, well, why do you need any funds at all? Isn't this a volunteer organization or a charity? And fair point. Someone like Pam to run an organization, though, probably wants to do it not entirely as a volunteer. And then a lot of the things that we're hoping to do, such as a patient conference or maybe a guest speaker or something, all of these things cost money. Or let's say we wanted to develop an app for your phone where you could learn about SADS conditions. All these things, as you all know, cost money. But we're excited to have an auction, which is a slightly new slant on this fundraising. And we're at the stage right now where we're really looking for your support and your network support to maybe make some donations of things that might be fun to auction. I'm going to ask my wife, who is a photographer, if she might donate a framed print or a framed photo for people to bid on. The bidding is not until later in the year, and I think yes, there it is on the slide, September 24th to October 1st. So, but we're still in the collection phase and getting all the prizes ready. So that's very exciting, but also a very important part of what we do here. And then a little bit closer in time on the schedule, this is just in a few weeks on July 8th. And this is a collaboration with our good friends and our partners at the SADS US Foundation, Alice, Lara, and Aaron, and the team, and Mike Ackerman. And we're all getting together and putting on what looks like a great program. Present company may be excluded. They snuck me in there a little bit as well. But there's some great talks, including some cutting edge information on research and some questions and answer period. And so get some information on the websites of either the SADS US Foundation or the Canadian SADS Foundation. And that's a Saturday, but what better way to spend a couple hours? It's Zoom, so it's virtual, so you can sit there in your sweatpants and the comfort of your home, eating popcorn and learning. So that's in a few weeks. And then I think those of you who've been following along, you can probably name all these people just like that. Part of our fun with this is to have a bit of a Canadian element, and so we've been doing fun Canadian facts. They've been very medical thus far, and the pictures they all look very homogenous. All these black and white of these very famous people. George Mines, a pioneer in the field, John Hopps, who was instrumental in developing the technology for the pacemaker. Edith Montour was last month, and we learned that she was the first First Nations nurse to be licensed. So today is a bit of more Canadian fun, and there is a connection to our theme today of HCM, or hypertrophic cardiomyopathy. Now, this headline, though, of course, says Toronto doctors on the track of diabetes cure. The date's pretty faded there, but March 22nd, 1922. So over 100 years ago, the discovery, of course, of insulin by a Canadian physician in Toronto and a medical student. So Banting and Best. And Banting received the Nobel Prize, and he was the first Canadian to win a Nobel Prize 100 years ago. And he, at that time, and I believe still, it was the youngest recipient of the Nobel Prize. Now, Nobel Prizes now, of course, come out a little bit faster. They used to take ages. So the gentleman who won it for the ECG, he got it about 25 years after the ECG. Nonetheless, so this is our fun Canadian fact for today. And I said it ties into our topic. Interestingly, a mom who has diabetes during pregnancy, the fetus sometimes can come out and look like they have hypertrophic cardiomyopathy. So diabetes and hypertrophic cardiomyopathy do have a connection. So a lot of fun facts. I'm delighted to introduce this month's guest, Dr. Thomas Roston. And I have had the privilege of knowing Thomas since he was a first-year medical student. And I have no idea when this photo is from, because it could be from yesterday or it could be from when he was a first-year medical student, because he has some sort of ageless appearance. And Thomas and I have had a wonderful time collaborating on a lot of research projects. We haven't spent a lot of time in what we're going to talk about today, which is hypertrophic cardiomyopathy, but we've done some other fun things. Now, Thomas did a ridiculous amount of training, all sort of while doing his clinical medicine. So he did adult medicine, adult cardiology, and then did a genetic cardiology fellowship, including some time in Amsterdam with Dr. Arthur Wilde, and some time at Boston with Dominic Abrams. And I'm dropping these names because these are world leading inherited arrhythmia specialists. And Thomas sort of slid a little PhD in there on the side of his desk. And most importantly, or perhaps not most importantly, additionally also participated in describing a new condition that we're not going to talk about today. We'll have him back sometime for that. But what is most important is that Thomas is one of the kindest and nicest individuals in the field. And even my family knows him and adores him. So that's a pretty gushing introduction. So now we're both embarrassed. Let's bring Thomas into the studio, and I'm going to stop sharing my slides here, and let's welcome Thomas.
Thanks, Shu. I really appreciate the invitation and the overly kind introduction. But yeah, it's a privilege to be here. And for the record, that photo is from 2 years ago. So.
All right, good. Well, you're holding up pretty well. I won't tell people how ridiculously young you are for your stage of accomplishments. So anyways, I've said hypertrophic cardiomyopathy about 20 times now, which is what we're going to talk about. Quite a mixed audience. Not everybody knows what hypertrophic cardiomyopathy is. Maybe give us a little high-level overview of what is even HCM, HOCM, IHSS, subaortic, hypertrophy. It's ridiculous how many names there are. Now I think we've settled on hypertrophic cardiomyopathy.
Yeah, so I think that's a great question. It's kind of a complicated question. What actually is this condition called HCM? But quite simply, it's when you you develop thickness of your ventricular wall, so the main pumping chamber of the heart, that's not explained by something else. So the most common reason we see it as people age is high blood pressure. So the heart works harder and you get this hypertrophy. But hypertrophic cardiomyopathy describes predominantly a genetic condition where you develop the increased thickness of your heart for unexplained reasons. And those unexplained reasons have now turned out to be genetic in many cases. But you can really get increased thickness anywhere in the heart. So depending on where you get the increased thickness, we've used many different names for the condition over the years, thinking that these were distinct individual entities, when in actual fact, hypertrophic cardiomyopathy is this highly complex condition that really can result in more of what we call obstructive physiology. So that was the name HOCM. We also have what we call apical HCM, which is when the tip of the heart is more affected than the higher up parts of the heart. So we have all different terms for things now, but probably the best term is hypertrophic cardiomyopathy. And I think we've settled there as a field, but definitely a complicated condition. And I think in many ways, a more complex condition than a lot of the inherited arrhythmia syndromes that we talk about also on this program and that SADS is very much involved in.
Yeah. So you mentioned high blood pressure. Earlier this month, I was seeing, a family, and the father at a middle-aged age was found to have a thick ventricle. So the main pumping chamber was a bit thick. So what I'm hearing you say, one shouldn't just go straight from, oh, you have a thick ventricle to I have hypertrophic cardiomyopathy. There's some other things to rule out.
Yeah, and I think that's the the incredible importance of being ideally seen at an expert referral center that sees a lot of hypertrophic cardiomyopathy, because this condition can look like a lot of other things that are more commonly seen in medicine, and also some rare things too. So most patients who get the diagnosis of HCM really should go through a number of rigorous tests to be definitively certain that this is the problem at hand. So yeah, it's not usually the quick diagnosis you can make on one echocardiogram, because it really requires a thorough workup.
And so let's take our hypothetical patient who is diagnosed with hypertrophic cardiomyopathy. Why is hypertrophic cardiomyopathy dangerous or not dangerous?
Yeah, so I think when I say that this is a condition that's a little bit more complicated than the other inherited arrhythmia syndromes, is that having a thicker heart muscle can cause all sorts of heart problems. So you can get heart rhythm problems from it. You can get dysfunction of the actual muscle where it gets stiff and you develop what we call heart failure. You can get a condition where the left atrium, one of the chambers of the heart, gets a bit bigger, and then you can get atrial fibrillation, which is a heart rhythm disorder as well. So you see this incredible diversity of how the condition manifests in each individual. And so, I think it's more complicated for that reason. So in that patient you described, what we really are left with is trying to figure out is, hypertension is so incredibly common in the general population. And it's a bit like lifting weights, right? So if you go to the gym and you lift 10-pound dumbbells for 20 minutes a week, and you call yourself a weightlifter and you've got super big muscles, that doesn't really make sense. So if you have really thick heart muscle and your blood pressure is only a little bit high, then that may still be this genetic condition called hypertrophic cardiomyopathy. But if you go to the doctor's office and your blood pressure is over 200 all the time, then maybe it's all more what we call hypertensive heart disease. So a lot of the nuance of this condition is really trying to tease out, how well explained is this increased thickness of the heart muscle. And that can be really hard in people who are older. So, I classify older as, over the age of 40 or 50. And in those cases, it can often be really hard. But the diagnosis can be a bit easier, I think, in younger people who really, have no other good explanation for why it's there.
All right. So you mentioned the weightlifter or the person that calls themselves an athlete. Let's talk a little bit about that, because I understand that especially in some of these high level sports, it can be very difficult to differentiate just an athlete's heart from an abnormal a concerning heart, and we've had some very famous uh, athletes die suddenly of hypertrophic cardiomyopathy. So is there, I mean, I keep hearing you say, it's not an easy distinction. We really need experts evaluating these families and doing the right tests. There's no kind of one, there's no easy, sorting out benign athlete's heart from dangerous hypertrophic cardiomyopathy in some of these cases.
Yeah, I think that's a huge challenge. So, depending on your ethnic background, your level of physical activity, your age, all of these things factor into how thick a normal thickness is. So, when we talk about athlete screening, or, making sure that people who are involved in vigorous sports are protected from having, dangerous heart rhythm disorders, sometimes separating that realm of what's normal from what's abnormal is a nearly impossible task. And I think that's a great application in the future for things like what we call machine learning. So it's a new technology that really, a machine learns what an athlete's heart is and what a HCM heart is, and it can basically apply a computer program algorithm and figure out, is this HCM or is this a more benign or non-life-threatening condition like athlete's heart? But we're faced with those decisions in medicine and in this condition all the time, and you make your best judgment in the moment, but it really can be a real challenge to make the diagnosis in those populations.
So we are not going to venture into the rabbit hole of talking about GPT and AI and the computers taking over the world, but I hear you absolutely that some of these, especially imaging, every week it seems there's a new study that shows that the computers are better than the doctors. And I know that even in the in the long QT field, we've had some papers about that on the ECG front. So let's say we have this man, 40 years old. He's diagnosed with hypertrophic cardiomyopathy. Tell me about the genetics of this. What you mentioned genetics has a role in this. What percentage of hypertrophic cardiomyopathy, the actual condition, will we find helpful genetic information, or is it not very useful?
Yeah, shoot. I don't know if you have some of my slides there handy, but the prevalence of gene positivity or finding the genetic explanation really depends on the type of hypertrophic cardiomyopathy you have, and also a lot on your family history. So if you have a strong family history of the condition, meaning somebody else in the family has a similar type of HCM as you, then the chance of finding the genetic explanation goes up. But what I tend to tell patients is the likelihood of finding the clear genetic cause, that this is 100% the reason you have HCM, is probably still under 50%. And that seems like a low number, but that's a pretty common number to quote in inherited heart disease. But the likelihood of finding the gene goes up dramatically if there are multiple family members who are affected, if it's a very convincing looking expression of the disease. And so it's a little bit hard to give blanket numbers, but about 30 to 40% will be gene positive, and somewhere around 40 to 50, maybe higher in individuals who have familial disease. Yeah, so I think I love this slide because it really gets at not only the different types of morphology of HCM, where the thickness is, but it also tells us a little bit about what proportion of individuals have each type, and then based on the type they have, you can tell them a little bit about, we're going to do genetic testing, but there's only maybe a 5 or 10% chance that we'll find the gene that causes it. So I think that's really a nice way to approach it. The one final thing I'll say is there's lots of fantastic research in the last 5 to 10 years that shows that the people who don't have a clear genetic explanation based on the type of genetic testing we do now probably have something called polygenic HCM, or polygenic risk for HCM, which really means that it's not one gene that's causing the problem. It's many genes, sometimes thousands or even hundreds of thousands of very minor changes in the genes that kind of all add up to causing HCM. So it's still often a hereditary disease. It's just our technology at this stage is not as good at identifying those people who have, multiple potential genetic explanations. And I think our field's going in that direction, where pretty soon families who are quote unquote gene negative HCM will be offered this thing called polygenic risk scoring, and it can give them a sense of a probability as to whether this is like a multiple genetic hit situation. So it's a complex question, but I think to this point, the simple message is the yield is probably overall less than 50%. But of course, still worth pursuing our standard genetic testing because it's important in those patients.
And what a great slide. And you might have some other slides where we'll go visual, but I'll take that opportunity to plug what I hope I say every time we talk about genetics. Always get the genetic testing done under the guidance of a genetic counselor. Mm-hmm. And I would always want people to understand the test. I think genetic testing is very complex, and we spent a couple of sessions with Melanie Kerr, just scratching the surface of how complicated it is. And the other very important thing that I'm hearing is, if the genetic test finds something actionable in 50% of the case, that does not mean that if the genetic test is not actionable, that you don't have hypertrophic cardiomyopathy. So it's very possible. And in that case, let's take this 40-year-old man who has, no genetic marker identified, and has a couple of kids. They would be seen, in a center a center that can see kids to look at hypertrophic cardiomyopathy, but you might not have the genetic marker to tell you whether they are or aren't at risk. Now, you mentioned risk scores, a polygenic risk score, and I know you've had some work with, especially from your time in Boston, with very large registries. Is hypertrophic cardiomyopathy as dangerous as we think? I mean, I feel like everything is skewed when you are speaking with a SADS lens, because people have had a very significant, rare, devastating event. But hypertrophic, how common is hypertrophic cardiomyopathy? I think it's much more common than some of the other conditions we deal with.
Yeah, so I think it's the most common SADS condition out there. It probably affects somewhere between 1 in 300 and 1 in 500 people. So most people in their high school class would have known someone who had HCM without being aware of it necessarily. So it is relatively common when you think about genetic heart disease. Prevalence and is how common it is in the population has become another challenging question to answer. So there's this amazing resource called the UK Biobank, which is I think now on the order of hundreds of thousands of people who have been kind enough to do a blood sample and get their genetic information sequenced purely for research reasons. And these are otherwise healthy individuals who, don't have any known disease. And the rate of finding what we call a likely pathogenic or pathogenic variant for HCM in all comers is somewhere around 2% in the general population. So there are people out there who carry these genes that are supposed to be causing HCM, but never manifest the disease in their whole life. And so it's interesting, they have this, what we call susceptibility to having HCM, but most people will never develop it. So it's really hard for us to understand what that means. But what it suggests to me, and what the data suggests more and more, is that in the minority of patients is HCM a very serious condition. And the risk of sudden death has actually probably been overstated based on early studies that looked at the most extreme cases. So sudden death is actually relatively uncommon in HCM, and most of my patients don't have ICDs. And we're getting better risk scores to figure out who's at higher risk of sudden death. But I think it's really important to realize there are many people out there who have a family history of HCM, who carry an HCM gene, who have a minor phenotype, meaning minor manifestations, and never really have a significant problem especially in early and midlife. And maybe as they get older, they're at higher risk of having things like heart failure. But I think the message is very positive from that perspective that, many patients are actually minimally affected by it overall.
Yeah, and we're going to come to some, some really positive recent research that that the SADS community was very involved in a moment to talk also about uh, athletics.
Mhm.
Before that, though, I just want, I want to make sure our audience really understands that HCM is it's a what I would consider a mixed disease, in that one can have I always joke and I refer to myself as an electrician of the heart, because I'm mostly involved with the electrical system, and my colleagues are plumbers. They're involved with the pump and opening blockages and things like that. Hypertrophic cardiomyopathy really is both. It's the electrical system and the plumbing. So you
Mhm.
can have an obstructed outlet to your heart and have a dangerous situation there. But you can also have abnormal rhythms just just because you have abnormal heart cells. And even the condition that we don't talk that much about in the SADS community, Wolff Parkinson White, but also a
Mhm.
cause of sudden death in young, otherwise healthy people, um, also travels with hypertrophic cardiomyopathy. So I agree. It's one of the most diverse conditions that we deal with. Now, you,
For
you
sure.
mentioned most of your patients don't have ICDs,
Mhm.
and obviously some of them are going to need some kind of treatment. Let's drill right down, though, on what I find one of the hardest conversations is, you have a 13-year-old who's been diagnosed with hypertrophic cardiomyopathy, or I'll let you have an 18-year-old because that's
Mhm.
more in your space.
Yeah.
Um, what can I do, doc? What are you going to let me do participation wise? And it's often framed that way, but what are you how are you answering that?
Yeah, I think that's a very common question. Part of the reason that's a common question, just to give some background, is that the early reports suggested that vigorous exercise might be associated with an increased risk of sudden death. And of course, that's the ultimate thing we want to avoid. But on the flip side, we've had more recent research that's really shown that, the hypertrophic cardiomyopathy community suffers from the consequences of being sedentary. So there's higher rates of obesity, diabetes. And then, if you go on to develop a second hit, like you get coronary artery disease later in life and you have HCM, that can sometimes be a significant problem. So you're kind of balancing, what is the risk and benefit of participating in exercise. So the way I frame this often is there's two main questions. The first question is, what am I physically able to do? And the second question is what is safe to do? So if you have severe obstructive cardiomyopathy, you face symptoms, and those symptoms are often breathlessness with exertion, chest pain with exertion, and even with really good therapy, sometimes people still have some exercise limitations. And so it's not realistic for that person to return to vigorous athletics because it's simply, not going to probably be possible, although return to some exercise is probably good. And then, you have the patient who's young, fit, strong, and, has a form of HCM that is either able to be treated well or doesn't cause a lot of symptoms. And those are the people who are often the ones who are quite motivated to return to even competitive sports. And so I think this was an area of controversy for a long time about whether this was safe or not. And we now have a great study that came out this year that you alluded to earlier, Shu, that had considerable involvement from the SADS Foundation, which was a multi-center study of examining patients with HCM who participated in vigorous athletics and people who participated in only sort of moderate to light physical activity. And what this large study of 1,600 patients with HCM showed is really, yeah, perfect. That's it there. Really, really perfectly shows that there doesn't seem to be any difference in the risk of major adverse events in patients who did vigorous activity and those who did not. So on the left-hand side of your screen there, you see what we call a forest plot, which basically suggests, are some of these adverse outcomes more common or less common in people who participate in vigorous sports? And you'll see that some of them err on the side of being beneficial if you do more vigorous, and some err on the side of being more beneficial if you do less vigorous. But overall, it looks pretty neutral. And then on the right hand side, you see what we call a Kaplan-Meier survival curve, which looks at the two groups and the likelihood of suffering an adverse event over the follow-up period. And the main point here is the lines are almost superimposed. So both groups had a similar rate of events, regardless of whether they did vigorous or non-vigorous sports. So this really, I think, gives us as a community permission to allow athletes to return to vigorous sports so long as they're well treated and optimally managed at an expert center. I think we can view this as being largely safe. And I think this is a huge development in preserving the quality of life in many of these young patients, and something that I'm in particular very excited about.
Yeah, no, and great that you had that slide anticipating our conversation would go there. The and congrats to Rachel Lampert and Mike Ackerman and the whole team there. That's such an important piece of data, because we've certainly been cautious. And again, another soapbox that we like to get on. It's not doctors or nurses giving permission. It's co-developing safe plans for healthy living. And certainly, most of the centers are very much encouraging people to be active with guidance, and that's very important.
And Shu, on that note, I know you're asking me questions, but I'll ask you a question for a change and say, you developed this amazing little card called Safe Sports that you gave to all of your younger patients, and it outlines a few key things that they have to be aware of if they want to participate in sports. So I think that's a great time to talk about that, because one of the things in HCM that's super important is hydration if you do have obstructive physiology and want to exercise. So maybe a good time to talk about sort of like what safety planning is around sports.
Yeah, no, thank you. And thanks for turning the table there. I even have one of these cards. I don't have I can't find it easily in my computer, and with the blurring, it's just going to be a mess there.
Yeah.
Oh, that's just the heart. That's just freaking people out there.
I think if you Google Safe Sports in your name, it comes up. Yeah.
But yeah, no, absolutely. And the card is just a good reminder to have the conversation. And it's very much exactly those principles. It's have the conversation with your healthcare team. What is it you want to do? So, I'll say there's nothing that I'm going to say no to, with your obviously with your parents' blessing, if you can come up with your safety plan. And your safety plan has to include compliance with medications. If you're on a medication, then you have to be taking it. You have to be nutritionally prepared for it. So, don't skip breakfast and then go on your first 6-hour hike. And, once the weather gets nice. And then hydration is key. And particularly, as you say, in hypertrophic cardiomyopathy, we showed you that graphic. You could see how small the pumping chamber can get. And that, you need to keep blood in there. So you don't want to risk things like being anemic if you don't have enough iron in your diet, or you don't want to have a no salt diet if you're a young athlete that participates in a lot of sweaty sports. So hydration, probably much more than most of our high school kids are drinking on a regular basis. And then, what's your safety plan? Who's your buddy that knows that you have a real health condition? So when you say I need a break, people aren't cajoling you or abusing you to keep going. So it's a very important conversation. And the kids, as people know, I only look after children and late teens, but I feel that they appreciate being part of the conversation. So when they're given the opportunity to come up with a safety plan, they're excellent at it. And especially now with their tech, they all have their phones, and their diagnosis is in their phone, and their meds are in their phone. So it's we've come a long way. We have just a few minutes, and I don't want to leave out some of this stuff. Our title, our provocative title, New Frontiers in Patient-Centered Care. There's been so much talk about two aspects, really. The first one I'll mention is a disease specific, so a mechanism specific treatment. So, tell us a little bit about that.
Sure, I'll just briefly touch on it, Chu, because I think it's a fantastic development in the field, but a complex one for sure. So this is development of a new class of drugs called myosin inhibitors, cardiac myosin inhibitors. So they actually make the heart contract less vigorously. And people with HCM, their heart contracts too much and is very thick. So this drug has now been studied in a randomized fashion, the highest quality of study that we have available, and it's now been approved by Health Canada for people who have the obstructive form of HCM that's present despite the therapies we have available already. So it's only really been available in the last 4 to 5 months, and it does about 50% of patients who take it have a significant improvement in exercise tolerance, and so it's a great new option, but it does have its drawbacks. It does require very close monitoring. So people who are on it need echocardiograms quite frequently, usually multiple times per year to monitor their response to the drug. But really a fantastic development. The current one that's available is called mavacamten, but there will be other ones down the road. And if you're a symptomatic patient with obstructive HCM, it's something that is the first sort of new development in this field in over 30 or 40 years from a symptom reduction perspective.
Yeah, mavacamten has been, as you say, just recently approved, but it's not a easy sort of. It's not like some of our other treatments. These patients are, followed very closely with regular echocardiograms and fairly frequent, because one has to get it just right if you're gonna start affecting the actual contraction of heart muscle. You have to be careful the pendulum doesn't swing. And then there's also some new treatments on the horizon, some genetic treatments for one type of hypertrophic cardiomyopathy. Are you involved at all in those conversations? Or, I mean, I know usually.
No, I'm not. The concept of gene therapy, I think, is really kind of developed in the last couple of years. So this is the idea that you could take a treatment that alters your genetics in a way that reverses the genetic problem that you have. So it's really altering the code that makes us each individual people as we are. So obviously there's ethical, legal considerations for all of that. There's safety considerations, but the field is advancing, and there is now, for a specific type of HCM called MYBPC3 HCM, that's the name of a gene, myosin binding protein C. There is a phase 1 clinical trial that's starting in the US to replace the defective gene that causes HCM with the correct one. And I think it's either started enrolling or it will start enrolling this year. So that might be a therapy for that specific type of HCM that comes to market, probably in the next 5 to 10 years. It would be my guess, but really exciting that we can start to talk about either long-term or permanently reversing the risk of developing HCM.
Yeah, and I think, we could have a whole session on just the history of hypertrophic cardiomyopathy, because it really, it's been such an evolution, and I feel that as you say, in 10 years, the treatment with these specific disease specific treatments, myosin inhibitors and gene therapies, the treatment might be quite different. That said, the treatments aren't going to be for everyone, and the criteria are going to be quite strict, and there is no treatment that is without risk. So, I think the big picture here is one really has to have an understanding of, what is my risk? Is it worth embarking on something that potentially has other effects? So, back to comments we made at the beginning of this, it's a complex condition that really needs expert involvement.
Yeah.
Um, Thomas, it's been absolutely wonderful to have this chat with you, and I think you and I could both talk about hypertrophic cardiomyopathy for quite a few more minutes about all the different uh, treatments and actual patient stories and research ideas. But we're gonna cut you short and let our audience and me get back to work, and you, of course. I will say that Thomas is one of the members of the medical advisory board for Canadian SADS Foundation. He very graciously accepted that role, and is actually going to look at our website and tweak our hypertrophic cardiomyopathy information on the website. So some of his great comments and insights will be there in a lasting form. Thomas, thanks so much. We're definitely going to have you back. Because it's so enjoyable, and you are doing so much in this field. Thomas is truly, he and a few other are really taking over the Canadian genetic cardiac disease landscape. So it's absolute privilege to have him here today.
Thanks, Shu. It's been a pleasure, and I really appreciate being able to chat with you today.
All right, thank you. So just thanks everybody. Such an enjoyable guy. I didn't tell him. I won't expose myself here, but under my scrubs, I'm actually wearing a shirt that he brought back for me when he came back from Boston, um, where he was a fellow. And but we don't want to get him too arrogant here. No, he's a wonderful guy, and we'll have to have him back to talk. The condition he described is closely related to CPVT, but it's sort of a cousin of CPVT. So, yeah, hypertrophic cardiomyopathy is there's a lot to talk about, and in fact, next month we're probably next month I believe we're having a guest that's going to take us into some of the basic science aspects of SADS conditions, including hypertrophic cardiomyopathy. So I think we'll wrap it up for today. As always, thank you so much for joining us, and I hope you've learned something about hypertrophic cardiomyopathy, and you have questions bubbling just as I do every time I think about these conditions. And then we will look forward to seeing you next month.